Hello everyone. I'd like to start by thanking the conference organisers for such a great event. I'm glad to be giving a talk here today. My name is Shane Burns and I'm the lead data scientist at Storm ID. At Storm, we work in partnership with the NHS to develop services and AI solutions to aid in patient care. Today I'm going to talk about some of the ethical considerations I have seen throughout this process and things that are necessary to develop effective solutions. The increase in volume and access to healthcare data has opened up exciting opportunities to apply AI in the healthcare space. These areas vary a lot. They include planning and logistics, which could be managing patient flow throughout a hospital, disease detection, which could be using deep learning over patient scans, treatment recommendations from reading radiology reports using NLP, and risk stratification, building models based off EHR data. With the growing adoption of AI in the clinical setting, it is essential to consider the ethical implications of any model that is developed. At Storm, we are very aware of the necessity of ethical AI. It is paramount that any model we develop doesn't have the potential to exacerbate any existing health disparity and that it complies with a consensus ethical framework. We draw from other bodies and thought leaders to develop our core ethical framework principles. We build our framework taking key ideas from the AI Code of Conduct, the 8 Caldecott principles, artificial intelligence at Google, the asimilar AI principles, and the Nuffield ethical framework. Some of the key themes common to each of these are transparency, fairness, and do no harm. So transparency in that we make any limitations of our models known, we make any limitations of the data known, fairness in that it's fairness to all groups, and do no harm in that it doesn't have the potential to do harm to anyone. Many recent health prediction models have been shown to perform poorly on women, racial and ethnic minorities. Ground truth diagnosis labeling, for example, has been shown to be gender skewed due to the different disease presentation in male versus female. These are the kind of things that can happen if we don't consider things like transparency, fairness, and do no harm. This study highlights one of the main problems occurring when training and validating clinical prediction models for cases where we have multiple data points for each individual. This could be a case where we have 10 years of EHR data for each patient, for example. So the problem here is in the use of record-wise validation versus subject-wise validation. In subject-wise validation, which most of the times is the correct approach to use, the same person cannot appear in both the training and validation data sets, whereas record-wise validation allows this, meaning that the same individual could have 4 years in the training data set, for example, and 6 years in the validation data set. The authors reviewed 369 articles which used patient wearable data to develop clinical prediction models. Of the articles that met the study criteria, so some of these criteria include that the authors stated what evaluation metrics they used, almost half of them incorrectly used record-wise validation over subject-wise validation. So the result of this was that in these cases, it gave misleadingly high results, and this is due to data leakage. So data leakage is where information from the training set essentially leaks into the validation set, and the fear here is that the model isn't actually learning the underlying condition, but instead it's learning the patient instead. Another very interesting study, which highlights a different ethical consideration, is around predicting pneumonia risk in patients. The authors were investigating what factors influence readmission risk and mortality when a patient presents with pneumonia. They found a very interesting observation in that patients who presented with pneumonia and asthma had a greater survival chance than those without asthma. So intuitively, when you step back and think about this doesn't make a lot of sense. The authors dug a bit deeper and they found that there was a confounding effect happening here, which led to the observation. Interrogation of the model found that the hospital's treatment policy was different for patients presenting with pneumonia and asthma. In these cases, the patients went to ICU for treatment and thus received more intensive care. Without such rigorous considerations, models may be blindly deployed and could have the potential to do harm. An extreme worst case scenario would be if this model was blindly deployed into a new hospital system which did not have the same procedure for treating asthma patients. The model would indicate that patients presenting with asthma and pneumonia needed less care, which definitely is not the case. I will use a toy example to illustrate some more ideas. This is a data set I've repurposed for this use case and isn't something which is in active development at Storm. So the case study I'm looking at is predicting osteoporosis occurrence in the Scottish population. This is a data set of 50,000 plus unique patients over the age of 40. Each patient has multiple years of data, anything up to 10 years of data per patient. And I'm modeling this as a binary classification problem, 0 for no osteoporosis, 1 for osteoporosis. Here are some of the EHR, or electronic health record, data sources used for model development. SMR01, this contains information around hospital admissions and can also be used to calculate presence of patient comorbidities. We have an ID for the patient, admission and discharge date. From this we can calculate the length of stay, the month of admission, for example, whether it was a winter versus a summer admission, and we have information around the diagnosis the patient got at discharge. So we have diagnosis 1, which is the main diagnosis, and then 2 to 6, which are the other diagnosis. We use these to calculate, for example, if a patient has osteoporosis based off diagnosis codes. The prescribing data, this is the history of all drugs the patients have been prescribed. So again, we have an ID for the patient, we have a prescription date and a BNF item code, which gives us full details around that. The final data set we'll consider for this toy problem is the SkyStore Labs data. This dataset contains info around lab test results that the patient has had. Again, we have an ID for that patient. We have the clinical code description, which describes the test in question. Range high value, highest normal value for that test. Range low value, lowest normal value. Quantity values, the actual result of the test, and the report date, the date of the test. We then calculate 50 plus features from this raw data, things like comorbidities to patient length of stay, and also min-max values of tests. 15% of the data is held back as a holdout test data set, and 85% is used for the model training and validation. Now we can evaluate model performance. I'll start by stating that this isn't a particularly good classifier, but we can use this to illustrate some of the points we discussed earlier. We'll consider record-wise versus subject-wise validation and examine any differences between the two. The first evaluation metrics we consider is the confusion matrix. We look at a validation data set, which is 20% randomly drawn from the 85% of the training data. So this validation data set contains 2,799 instances of where the patient did have osteoporosis. This is the top row, and 65,155 instances of where the patient did not, the bottom row. So you can see that this classifier does okay with osteoporosis patients, gets it right a bit more than half of the time, but it also falsely predicts a lot of people who did not have osteoporosis as having osteoporosis. The subject-wise, this is roughly 20% drawn from that 85%, but in this case, we make sure that there are no patients who are in both the training and the validation data set. That's why there's slightly different numbers between the two sets here. The validation data set contains 2,729 instances of where the patient did have osteoporosis, which is the top row, and 65,225 instances where the patient did not, the bottom row. So again, it's quite similar performance to record-wise, although not quite as good. So if we look in terms of the classification report in the top right, we can see that for record-wise, the F1 score is slightly higher than for subject-wise, meaning that here record-wise is performing better than subject-wise, which is kind of what we expected from the slide earlier where we discussed this. To fully evaluate the two models, we now go back to this 15% holdout test data set from the start of the problem. We can see that there is a drop in performance in the model trained using record-wise validation and a stable performance of the model trained using subject-wise. This means that the record-wise model did not generalize as well to unseen patients, and the subject-wise model did generalize well. This is this effect of data leakage, where in the case of record-wise, information from the training data has leaked into the validation data set, and hence these are the results. We shouldn't just stop here though. This analysis should also be extended to see how the model performs on different subgroups. So for example, here you look at performance on female versus male, or look at performance on different ethnicities. I will now extend this problem to highlight the biases that can occur in a model due to missing data. With sparsity-aware algorithms which can handle NANs, such as XGBoost, it is tempting to just carry on without fully investigating why certain values may be missing. For this case, we artificially introduce BMI, so body mass index, into the training data in a missing at random fashion. Retraining the model using subject-wise validation gives the following results. So we can see a massive increase in model performance. It's now a very good classifier. We can look at the AUC ROC of 0.98 and the area under the precision recall curve of 0.9, meaning this model is performing very well. We now go back to our holdout test dataset to see how this model generalizes to new patients. If we look at the confusion matrix and if we look at the classification report, we can see that there is a significant drop in model performance. This model did not generalize well to new data due to the bias we may have introduced. The model predicts the no osteoclast as mostly having osteoporosis, as can be seen from the bottom row of the matrix. So in the case of the holdout test data set, it has mostly complete BMI data. This calls for some further exploration into why there is such a drop in model performance. We can use feature importance and model explainability to investigate why the model is not generalizing well to this new data. So SHAP, which is Shapley additive explanations, is a very powerful technique for obtaining model explainability. If we look at the bar chart from top to bottom, we can see the most important features to the model. And by far the most important and dominating the others is BMI. So this newly introduced BMI variable, which had a lot of missing values, has all of a sudden become the most important. We can now look at the SHAP summary plot to gain more insight. Blue represents low feature values and red represents high. If we take age, for example, we can see that low age is pushing the model to the left, which indicates no osteoporosis, and high age is pushing the model to the right, which indicates osteoporosis. This is what we would expect. The dominating feature, however, BMI, as we see at the top of the graph, has a lot of grey values. So grey here indicates a NAN value or a missing value, which is then pushing the model to the left. So it turns out that the missing data we introduced was mostly in the case of people who did not have osteoporosis. This type of bias is very common in a medical setting, as the presence of certain data often correlates to a certain condition. For example, in this case, osteoporosis patients in the training data, which may have been drawn from a certain hospital, routinely get their BMI checked as part of normal procedure. When we then applied the model to a holdout test data set, which could have been drawn from a different hospital, where all patients have their BMI recorded, it did not generalize well. The model essentially learned that having no BMI data means you don't have osteoporosis. So this is a very bad bias that we introduced, and a good illustration of some of the ethical considerations needed here. SHAP can also be used to get local feature importance for individual predictions. Here I have two such examples of where the model got it wrong. In the left figure, the patient has a BMI value, and the model is therefore pushed to the right to predict osteoporosis, incorrectly in this case. In the rightmost figure, you can see that the patient did not have a BMI value, and the model is therefore pushed to the left to predict no osteoporosis. Again, this is a case where the patient did have osteoporosis. So this allows us to see why the model is making the mistakes that it is. This can also be extended to look at subgroups, so feature importance for male versus female or for different ethnicities, allowing full interrogation of any model that you develop. I hope this talk has given some insights into the type of biases that occur during model development in the healthcare setting. Just to summarise, it is critical to consider the ethics of any model you develop. It's never enough to finish model development when a certain accuracy metric has been achieved. The model must always be interrogated. Model fairness should always be tested. You should always test on different subgroups, so as mentioned throughout the talk, male versus female, different age groups, different ethnicities, to see how it performs across the full population. Model explainability is paramount and essential in the clinical setting. As illustrated by the last example, this explainability allowed us to realise the limitations of the model and to realise where the biases were coming from. So for some more information on this, a good watch, which many of you might have seen, is Coded Bias on Netflix, and a very good read on this topic is Weapons of Mass Destruction by Cathy O'Neill. Thanks very much, everyone.